Welcome to the Affirming Minds Podcast, where we equip like-minded mental health professionals with a therapeutic toolkit that helps add to a more engaging, fulfilled, and effective mental health practice. Each empowering episode can stand alone as a continuing education pod course or a very valuable professional or personal resource with insightful expert interviews, practical resources, industry news, and lots of inspiration. We help the modern therapist thrive at work. Now let's welcome your host, a dedicated therapist and passionate educator, Shaina Siber, LCSW.
Welcome to the Affirming Minds Podcast. I'm your host, Shaina Siber. Before we dive into today's episode, I want to take a moment to share some important disclaimers. This podcast is for educational purposes only and should not be considered a substitute for professional treatment or clinical supervision. Confidentiality is always a priority. Any clinical examples shared in this episode are de-identified composites or clinical vignettes, ensuring that no real client-patient health information is disclosed. If you're interested in earning continuing education credits for this episode, check out affirmmentalhealth.com to learn more about our membership options. Membership includes CEs for live virtual workshops, self-study webinars, and pod courses via the Affirming Minds podcast. In today's episode, we're taking a deep dive into eye movement, desensitization, and reprocessing, or EMDR, a powerful evidence-based trauma therapy that has transformed the way clinicians approach PTSD and other distressing life experiences. You may have heard of EMDR as a highly effective treatment for trauma, but what does it really look like in practice? How does it compare to other gold standard treatments like cognitive processing therapy or prolonged exposure? And how can clinicians integrate it into their existing work? To answer these questions and more, I'm thrilled to be joined by Elizabeth Armstrong, LCSW-R. Elizabeth is a New York City-based psychotherapist, EMDRIA-Approved Trainer and Consultant, certified schema therapist, and certified meditation teacher. With over 20 years of experience specializing in trauma, anxiety, mood disorders, and personality disorders, Elizabeth is known for her integrative and deeply compassionate approach to treatment. Trained at Columbia University and the National Institute for Psychotherapies, she blends EMDR, schema therapy, and meditation to foster transformation beyond intellect, working at deeper emotional and somatic levels. She runs a thriving group practice on Manhattan's Upper West Side, facilitates EMDR trainings, and leads immersive workshops for clinicians seeking advanced trauma-focused skills. Elizabeth has presented at international conferences, including the EMDRIA Conference and the International Society of Schema Therapy, sharing innovative techniques that combine EMDR and schema therapy for profound healing. Currently, she is expanding her expertise by pursuing a psychedelic-assisted psychotherapy certification through the Integrative Psychiatry Institute. I'm so excited to have Elizabeth here today to help us break down what makes EMDR such a unique and effective trauma therapy and how it differs from other treatment modalities and how therapists can incorporate this into their clinical work. So let's get started. Elizabeth, thank you so much for being here and joining us on the Affirming Minds podcast. I would love to maybe just start having you introduce yourself to our audience and share how your professional journey led you to specialize in EMDR therapy.
Yes, absolutely. And Shaina, thank you so much for having me here and inviting me to speak about EMDR, a treatment I'm very excited and passionate about. So it is wonderful to be here with you. I guess I can explain my journey to becoming an EMDR therapist, which I think, like many therapists, my journey came from my own personal background of having experience with trauma and intergenerational trauma. So I really know firsthand how trauma can negatively impact and shape lives, even generations of lives, when not addressed and healed, but also know firsthand that deep healing really is possible. I was always interested in people, humanities, literature. I'm a big musical theater kid, and I was a psychology major in college. And I began seeing trauma as early as those college internships. I worked with survivors of domestic violence. I worked with children who had experienced abuse at the hands of the very people who were supposed to care for and protect them. And then after graduate school, I worked for many years in a partial hospital program here in the Bronx with a wide range of diagnoses and obviously PTSD and trauma amongst them. And on one hand, I was always really amazed and inspired by the human resilience, creativity, and strength of people. But on the other hand, I also felt to some degree helpless that the tools I learned in graduate school and undergraduate were simply not enough, were not deep enough. I was not equipped to treat these clients that so desperately needed healing. Some clients were able to get better with the therapy we offered in medication, but many were not. So again, I think like many therapists, I had a training frenzy where I trained in CBT, DBT, mindfulness, IFS, you name it. And a lot of the modalities I still use today, they are incredibly useful. But it wasn't until I found EMDR here in New York City, I signed up for Dr. Zangwill, who's my now dear friend and mentor. I signed up for his basic training. And from that first day, I was like, oh, wow. Just what he had us do was a lot of practice. So we got to be the clinician, the client, and an observer and really feel for ourselves how powerful the tool was. Because when you hear about it, and I know we'll go into what it looks like, it sounds very strange. It sounds like I couldn't really believe it. I was a little bit of a cynic. But it wasn't until I felt it for myself, both in the basic training and as a client myself, that I was just so excited by the power, how it really helped link, not just I could get people to know they were safe and know intellectually that they weren't a bad person, they were good, but they didn't feel it. And there was something about EMDR that really helped people connect what they knew with what they felt in a much deeper way that I've been very excited about.
That's really beautiful to hear you talk through. And I appreciate being such a well-rounded clinician and seeing the utility in a lot of different training modalities. But when you have a personal transformation and something really clicks, both being deeply committed as a therapist, but also holding that perspective as someone who is suffering, who may benefit from this treatment from the vantage point of a client. And we were talking out offline about the importance of sometimes centering our lived experience, to dismantle some of those sometimes like us versus them hierarchies that sometimes can be talked about in clinical education. So I think that's so powerful. That was your entry point. And I love that you came in cynical, because I think I am someone coming through like really with fresh eyes to EMDR, and the approaches are very novel and different than a lot of traditional talk therapies. So I think that that's just like a very authentic take for people who are outside of the EMDR community. They're like, what is this? What are these buzzers and lights and things that are being integrated into treatment? So I really appreciate you sharing that experience. For those who are unfamiliar, how would you describe EMDR in simple terms?
Yes. So EMDR stands for eye movement, desensitization, and reprocessing. And it's already not simple, right? It's a mouthful. But quite as simply as I can put it, it's an 8-phase memory-based psychotherapy that was developed by Dr. Francine Shapiro in the late 1980s. And it really helps us process, integrate, and heal from trauma and the impact of trauma and other distressing life experiences, so that we're better able to feel a sense of hope, agency, and being present in our lives, really like the past is in the past. And it's a 3-pronged approach. So it has a way to address the past, the present, and the way we and our clients look at the future. And I'm happy to unpack that a little bit more. So EMDR posits that many of our problems and symptoms, both psychological and also sometimes physical, are caused by the failure to process and integrate painful and traumatic memories and experiences. And what I love about EMDR is that Francine Shapiro really believed that much like our bodies have an innate capacity to heal, we also psychologically want to move naturally towards healing, towards an adaptive resolution. So if you have, let's say, an argument with a friend or a colleague at work, you know that for that day or the following days, you might feel activated, upset, right? And you feel it in your body. You want to tell people, you journal, you take a brisk walk, right? You do whatever it is that you do to regulate. And then you notice over the next few days, it's less distressing. It gets integrated. You might learn from it and you move on. But when something traumatic happens, this adaptive information system gets overloaded and the memories get stuck in our nervous system in a state specific form in the way they occurred at that moment. So they have the images, the sounds, the smells, even the tastes, the urges, the cognitions, the emotions and body sensations that happened at the time. And they're siloed, isolated in the nervous system. They're away from any adaptive material. They're far away and isolated. And then when we or our clients are moving throughout the present and we get triggered, and that could be anything that's even remotely like that experience, a facial expression, a tone of voice, a sound, a smell, the past becomes the present. We're triggered and it looks like symptoms. It can be flashbacks, nightmares, hostility, fear, terror, etc. So in EMDR, it was designed to ask a targeted set of questions to activate these memories and then add what we'll go into the bilateral stimulation, the eye movements or taps or tones, to jumpstart that adaptive information processing system to move these memories toward an adaptive resolution so that we can be in the present and put the past in the past.
Yeah, I love how you language that too, that the past becomes the present. And I have seen that as such an experience of folks that I work with that are experiencing trauma, anything that has any structural similarity, that it does feel so imminent in terms of their experience. That was really helpful to understand the theoretical framework that's supporting this treatment. And I think it really resonates in understanding when working with people who have experienced trauma and how it shows up in their daily lives.
Yes.
So, given that, would you walk us through those 8 phases of EMDR and explain how they work?
Absolutely. So we start, like many psychotherapies, with taking a really good history. And all throughout this, we're also focusing on the really good relationship. That's really important to EMDR. And in that history, of course, we're getting the reasons for seeking treatment, the symptoms, the strengths that they have, the positive things they have in their lives, the support systems. We want to know about their trauma history. I like using Dr. Howard Lipke's Great Lakes questionnaire. It's not as well known, but it also assesses for strengths and things that other people might not think of traumas, those small T traumas that are not necessarily shock traumas, but are cumulative, like having very critical parents or a horrible breakup or things that really stick with our clients or being bullied. We also want to ask about their medical history, their culture, their cross sections of identity, spirituality, gender identity. And we also want to pay particular attention to things like dissociation and maybe an ACE score, which is the Adverse Childhood Experience score, because we know that the higher score there will be correlated with more symptoms later in life. Then we go into what's called the preparation phase. Because EMDR can be more intense than some other psychotherapies, right? We're intentionally bringing up the trauma, we're activating it and accessing it. We really want to get informed consent for that. We want to prepare them that this could be intense, this could be activating, but we're here with you every step of the way. And we help the client resource, and we'll talk a little bit later more about resourcing, but basically anything that helps their system regulate, feel calm and sturdy in the present. And the sky's the limit here in terms of the creativity and imagination of the therapist and the client. So it could be a place, it could be a symbol, it could be a time that they felt really sturdy in the past, anything at all. It could be a pet, it could be a beach. So anything that they have that we know they can regulate. In preparation, I also want to make sure my clients can maintain enough what we call dual attention. And that means we always want them to be able to have one foot in the present with us, their adult self with us, safe enough in the present, and one foot in the past or in this free associative reprocessing experience that is EMDR. And so I just want to make sure my clients are able to do that well enough before we go into processing. We also explain what EMDR is, what it isn't, right? They're going to come themselves, they'll leave themselves, they're not going to forget the memories. And then we introduce the BLS, the bilateral stimulation. So I'll show them the eye movements, the taps, the tones, and have them choose which bilateral stimulation they would like to use for the processing. We also emphasize they can stop at any point. So really giving a lot of choice and agency, because so much of trauma is the helplessness and the powerlessness. So really letting them know they're in control, they can stop at any point. And all that's happening is that brain waves are firing, right? They're safe with us. So that's what we do in the preparation. And in the assessment phase, phase 3, that's where we're choosing and activating those traumatic or disturbing memories. And we bring them up vividly and multidimensionally. We get an image, a negative cognition, something like, I'm bad, I'm not safe, I'm not good enough, I'm a failure, that they associate with this memory. We ask them what they feel, and often shame or fear. And we ask them, where do they feel it in their body? And we ask them how disturbing or distressing it feels to them now before we start the treatment. We also ask them, what would they rather believe about themselves when they think about this trauma? Something like, I wish I could believe I'm okay now, I'm safe enough, I'm a good enough person, I can make mistakes and still be okay. And we ask them how true that feels to them now, not then, we can't do anything about back then, but how true it feels now. And we set it up right before the processing. And that's the target assessment. And then phase 4 is desensitization. And that's what most people think of when they think of EMDR, when they've seen videos of people moving their eyes or tapping the butterfly hug. That's where we're at. We're bringing up that vivid image. And then we're adding the BLS. We're asking the client to move their eyes following either our fingers or a light bar, or we ask them to tap themselves, or they listen to tones, or a combination, any bilateral stimulation. And this is where it can be incredibly exciting, and where we let their system go wherever it wants to go with as little judgment as possible. So they do the BLS for a while, then we stop them and we check in with what they're noticing. And it can be anything at all. Sometimes it moves throughout the body. Sometimes people have waves of other memories that felt similar. Sometimes people go through their old childhood homes. Sometimes they go chronologically. Sometimes you're not sure where it comes from, but it's amazing where people go. And it's incredibly one of the most exciting parts for me as a therapist, just witnessing and holding that space for them as their system does what it needs to do. And the desensitization is considered complete when the disturbance level is a 0, neutral, or 1, or something ecologically appropriate. Some things will never be a 0. And I think that's right. We have to make a clinical choice as when is this resolved enough? Is the distress down enough? Once the disturbance is down, we move to phase 5, which is called installation. And what this is, we want the memories to feel less distressing, yes. And also we want something new to happen. We want that new adaptive learning to happen. We want them to relate to that memory in a healthier, fairer, more adaptive way, so that when they bring up this memory now in the present, instead of saying, I'm bad, they really feel, I'm good enough. I was just a kid. I'm a good person. I'm okay now. It's over. I'm safe enough. We really want that felt sense. And so we do bilateral stimulation where we pair that originally painful picture with the positive belief. So a painful image and I'm good enough. And then we do more BLS. And we do that until it feels true, like a 9 or a 10. Although I have many clients who are not a 10. I'm not a 10 person, they'll say. So we get as close to 10 as we can, where it really feels true enough. And then we move on to the body scan. That's phase 6. Body keeps the score, right? So we want to check when we hold this painful image or previously painful memory and that positive cognition, right? This childhood painful image with I'm good enough. And then we ask them to scan through their body and notice where they feel anything at all. And we're looking for dissonance, residue, right? I feel like I'm good enough, but oh, my throat, something that locks up there, right? Or oh, in my belly, I'm not sure if I'm good enough. I still feel something there. And if they're still not clear in the body, we do more sets of bilateral stimulation. Once the client feels calm, centered, they're not reporting any more distress in their body, we go to the closure phase. And that's where we check the SUDS and the VOC. That's a 0 and a 10. That's considered complete. The distress is a 0. How true the positive cognition feels is a 9 or 10. We debrief the experience. We ask the client what they learned, what stands out to them. If it's someone we've been working with, we also point out connections that we saw. And if there's still some distress, we also want to make sure they always leave feeling oriented and safe enough. So in the closure, we can offer containment, we can offer relaxation exercises, and some clients just want to chit chat, and that co-regulation really helps them the most. Whatever your client needs to feel safe enough. They might feel grief, they might be upset, right? So that's okay, right? Being able to tolerate this can stir up a lot of grief. There can be sadness, there can be pain. We always have them leaving feeling oriented and safe enough. And then the other part, I love the final phase of EMDR, the reevaluation, which I find, at least in my own therapy and in work I previously did, was really missing. To come back and check on the work. Is the client getting better? How did the week go? Were they triggered? Were there things that usually would trigger them that didn't trigger them, right? I had someone say, wow, I went to this family reunion and usually that uncle just, I react to him every time. And this week, not so much. What that piece we worked on really seemed to help me not get triggered. So we check in with how the processing sat. We ask them again how they feel when we bring up the image. We check how disturbing it feels, how true the cognition feels. And it's always important that for the continuity that we come back to that memory and check in. And that is the 8 phases. And final point about it, they are not linear. So you might work with somebody, especially with complex or attachment trauma, where you process something and then things happen in their life. They get destabilized. You're back to preparation. You're back to more talk therapy sessions. That's absolutely normal. And then we go back to processing when they feel ready and regulated enough.
Yeah. Thank you for walking me through that. Personally, I feel like that was really helpful to think about those different dimensions of it. And I think that's really what I was struck by, the multi-dimensional nature, like how holistic it is, and thinking about these different ways that trauma affects our lives, like taking this strength-based perspective and giving folks the resources to navigate this safely, but really going into the depths of the trauma material, and then also dealing with both beliefs and the way that trauma physically manifests. So I think I'm just hearing about the richness of what we now understand about trauma and how it shows up. It has a really comprehensive approach in targeting all these different domains and how they're impacting someone's life. So I really love that. And just that you kept on like that languaging of enough, safe enough. Do you believe it enough? I think that also is helpful just in terms of the like keeping things flexible and also not subscribing to absolutes, particularly like in our modern world. I worked in a very similar population in the Bronx, so to have someone walk out with like a sense of absolute safety, I think we'd be doing a disservice if we're making false promises to people about their very valid like safety concerns and things like that. But I think getting to a place of resolve where it feels ingrained and internalized enough to navigate one's world in a different way is like a really nice place to land. So really appreciate that. I know you mentioned that informed consent is such an essential part of this process. And I know you started to speak to it, but for you, is there anything that therapists should be keeping in mind in terms of how they are communicating true informed consent in the context of EMDR.
Yes. I don't go through the 8 phases with everybody ahead of time and name it. I don't want things to feel too jargony, except for some people where it actually gives them comfort to have a lot of knowledge, and I know who those clients are and do go through it in more depth. I think in terms of just letting them know that we are going to activate and access these painful memories in a multidimensional way, but always letting them know that we're not going to do that until they feel prepared enough. That's why we do the resourcing. That's why we have a really good enough relationship with them ahead of time, and that they can choose the memory that they want to work on and that they can stop at any time. That all that's happening is that brain waves are firing. They're safe with us in the present. I think all you need to do for this informed consent, because I also don't want to emphasize that it's terrifying or something bad is going to happen. It can be activating, but sometimes there's no better resource than doing this and realizing, oh my gosh, I'm okay. I did it. And it really went well, or I feel relief, or it was hard, but I went through it. So I think as long as we're really having this good enough relationship, we are letting them know what it's going to look like, giving them a lot of agency, choice, and control. I think that's really giving them full informed consent.
Yeah, absolutely. So obviously, the bilateral stimulation is a novel and key component of EMDR. Could you talk more about its role and why it's effective and how it facilitates trauma processing?
Yes. So when we talk about bilateral stimulation, we call it BLS. Sometimes you'll hear us refer to it. That is, Francine started with eye movements. That's why it's in the name of the therapy. She found out by walking and thinking about something distressing by accident that when she was moving her eyes back and forth horizontally just on a walk, she noticed the distress level go down. And from this, she developed EMDR after many, research and many steps, of course. In addition to using eye movements, as I mentioned, we now can use taps where a client taps on either side of their chest like a butterfly hug. We also have equipment where there are paddles that vibrate that go back and forth, left, left. We have headphones that can do tones to the left ear, to the right ear, back and forth. And we think that something about the bilateral stimulation jumpstarts that adaptive information processing system to help memories move towards that adaptive resolution that we're already wired to do so, that our system wants to go there. And something about the BLS jumpstarts that system. But the truth is, we honestly don't know why it works. We know that it does work. It is one of the most research-based therapies that we have, but there are some hypotheses. So we used to think that when you brought up a memory, it was like you were pulling a photograph out of a drawer already formed. What we now believe and what neuroscience seems to support is that each time we ask our clients or we bring up a distressing memory, we're actually building it in our mind's eye in that moment. So that means that every time we rebuild it, there's actually an opportunity for a revision. So if we're building it and then we tax the working memory by having someone have to follow something with their eyes or tap themselves or attend to a vibration, right? We're taxing the working memory so that they're not able to build it as effectively. So the image degrades. They don't forget it, but it moves further away. They can't build it quite as vividly and painfully. So that's one idea, that we're taxing working memory, or that something about memory reconsolidation. We're adding the BLS, which is soothing the system while we're bringing up this painful memory. So it gets digestible. It gets more easily digested and integrated so the person can heal. Some other theories, Francine Shapiro's original theory was that something about the eye movements maybe mimicked REM sleep. And we know that's the phase of sleep where we dream, where some people think that's psychological processing, digestion, right? We take what we need to remember from the day and we shed the rest and move on. That's something about the BLS, particularly eye movements, might mimic this. Another theory is that there's something inherently relaxing about BLS, that something about the tapping or the moving back and forth actually triggers the parasympathetic nervous system, the rest and digest part of our nervous system, so that it's actually soothing and relaxing. Again, these are hypotheses, but we really are not sure why it works.
Yeah. And that's so fascinating to see how things are evolving and understanding how we access and store memories. And that's sort of maybe unlocking new insights into, again, why we understand certain therapies to be effective, but also evolving things and moving things forward in terms of recovery efforts. So that's um, really interesting. Could you perhaps speak to how EMDR differs from other trauma-focused therapies, such as cognitive processing therapy or prolonged exposure therapy, often thought to be gold standard treatments for PTSD?
Absolutely. So I should start by saying I'm not formally trained in either. And you're absolutely right. I believe EMDR, prolonged exposure, and CPT are gold standard treatments for PTSD. All have been shown to be effective for PTSD. I do know that CPT and prolonged exposure focus more on cognitions, and they focus more on recounting and retelling the trauma again and again. And for some clients, I know this has been incredibly helpful. So if this is a modality that works for you, that is wonderful, right? We want people to find whatever healing modality helps them. That's wonderful. I think what is different about EMDR, and maybe why I'm drawn to EMDR, is it's more experiential. Again, it's really trusting the client's innate capacity to move towards healing. It uses bilateral stimulation, which we just talked about, which the other modalities do not. And what I can think of where EMDR might be a little bit preferred as a methodology is if a client doesn't want to talk about their trauma explicitly, there are ways to adapt EMDR. I always want my client to feel they can tell me anything to their comfort degree. But if it feels too painful or too shameful, or it's pre-verbal, there's no words, it's really in the body, right? We have ways we can adapt EMDR to treat that symptom anyway, even if we don't have the words, and move it towards an adaptive resolution. So I think for clients where they might not want to, or they can't verbalize, or it's very somatic, EMDR might be the choice, the modality of preference. But again, you're absolutely right. I believe all three of these modalities can treat PTSD.
Yeah, that's really interesting. I do run into that so much in trauma work that significant trauma experiences have happened perhaps before the age of 6 or often before the age of 3, and someone has awareness that they've been exposed to trauma, and clearly there's impacts on their lives. And as you mentioned, they don't have access to the conscious memories. They don't have a way to verbalize it. And that can sometimes feel a bit more of a stuck point in certain directly verbal therapies. And also different levels of readiness. So that things that are very focused on exposure as like the primary modality or cognitive processes and the function of cognitions in someone's experience of PTSD. I could definitely understand how the flexibility might be very welcomed by certain clients. And I think that flexibility that you even described in that flexibility in terms of protocol, that treatment can pause, be more supportive at times as day-to-day stressors come up and need space and the relationship building happening around that. And I think that is also deeply meaningful, probably from the patient experience, because they're coming in wanting support and have like their own areas that need attending to, and they may not always align with the protocol or a manualized process. So I really appreciate that flexibility seems to be so built into the practice as you describe it.
I think that's a great point, Sheena. Absolutely.
Yeah. So EMDR is widely recognized for treating PTSD, for treating trauma, but Are there any other conditions or clinical populations where it has been proven effective? I know you mentioned the small T traumas and that it sounds like there is integration to the work for people where they may not qualify from a DSM-5 as a criterion A trauma. So I'd love to hear your thoughts on that.
Yes. So you're right. For PTSD, the World Health Organization, NAMI, the APA, the VA all endorse EMDR as the gold standard treatment for PTSD or one of the gold standards of treatments. And we certainly do have the most robust and earliest research about PTSD. However, it's definitely being used now for a wide range of issues for anxiety, depression. I find it particularly powerful with grief work, attachment wounds, performance anxiety, chronic pain. There's even studies, I don't do it in my own practice, but there are even studies with EMDR and schizophrenia, not to cure schizophrenia, but to reduce the symptoms for symptom reduction and symptom relief. So it's really being researched now with a wide range of issues with really nice results. So yes, it's absolutely applicable to many other populations and many other issues other than just PTSD.
Yeah, that's fantastic to hear. How would you say that EMDR can be adapted to work effectively with clients from diverse cultural backgrounds?
I think because EMDR is very client centered, very collaborative, and again, emphasizes the client's inner wisdom, not mine. I think it's an ideal therapy for clients from a diverse range of backgrounds. And when we think back to those 8 phases, when we're doing history taking, we're going to be with respect and sensitivity and consent, asking about these things about culture, about ethnicity, race, immigration experiences, intergenerational trauma, systemic oppression, all the cross sections of identity, sexuality, gender identity, right? So we're also getting that in our history taking, in our relationship with the client. And when we talk about in preparation with the client, I mentioned that we use whatever the client feels helps them feel calm, sturdy, and secure. So we can draw upon whatever their cultural values resonate for them. If there's a spiritual figure, a wise figure, I had a Chinese artist. She drew this amazing dragon and her little girl self, and she would imagine that dragon coming to protect her during her processing. And then in the integration phase, when clients are processing and integrating what they learned from the experience, you can use art, music, movement, anything that person feels is healing from their culture is really we're able to utilize for preparation, for integration. When we're doing phase 3, again, the client is identifying what memories they want to work on. I'm not dictating it. And I think as long as we're intentional, we're authentic, and we approach everything with respect and consent and honor the client's unique identity, values, and lived experience, I think EMDR is a really wonderful modality for a wide range of backgrounds. I've worked with a lot of second generation clients where there's that tension between their parents' culture and trying to grow up here in the United States. So parents from China, Iran, India, Dominican Republic. And I worked with a number of Hasidic Jewish men actually with their tension between being in the community and partly wanting to leave. EMDR was effective with a wide range of my clients from different places, different backgrounds.
Yeah, no, it's so interesting to hear. It sounds like it really lends itself to having a culturally humble perspective because there's so much curiosity and interest that is done upfront about understanding the client well and all of these different intersecting parts of the person's identity. And it sounds to your point that because it's so client led and there's so much choice, and it sounds like so much continuous checking in around choice, and that it really maps onto a lot of those core trauma-informed principles inherently. So I think that's really important to understand about how the treatment functions in that way. So can you explain the importance of EMDR and maybe share an example of a resourcing technique that you use?
Yes. So, resourcing in EMDR, sometimes called RDI, resource development and installation, is again part of preparation, but it can be woven through any phase of treatment and in between sessions. And again, what we're really trying to do is improve our clients' ability to adaptively change their affective and behavioral state prior to the formal processing. So we want to help them access these specific affirming and healing memory networks. And what I mean by that is we might have them think of a safe enough place. And much like the target assessment accesses and stimulates painful memories, here, and that's usually quite easy for clients actually to think of. If I ask you to think of a painful memory, that usually comes quickly, right? We are wired for survival, not to be happy. So, what's harder for clients often is the resourcing, is to intentionally focus on positive self states, positive experiences they've had. And for our clients who've had fewer positive experiences, we can install them, so to speak. We can help sculpt them with our clients. So we can have them think of somebody they admire and a quality, that person that they would like to have and embody more, and have them really vividly visualize that person and ask them, when you think of this person's courage, what words come to mind? I am brave. I am strong. Great. And where do you feel that in your body? I feel that courage in my heart. Wonderful. And you really make it as vivid and rich as possible so that the client has this sense of sturdiness or strength or whatever quality you want to enhance. And then you can also add slow, short sets of that bilateral stimulation once the client feels it's vivid enough to really enhance and strengthen that resource in their system. And this, again, can be used to make sure they have enough sturdiness before going into processing. It can be during the desensitization phase when they're in the processing, like that woman I mentioned who would call upon her dragon to protect her when she was going into her 2-year-old memory. Or it could come after when you're doing a closing phase and you're asking, do you want to go to your safe enough place? Or do you like to spend time with your protector figure? It could be something in nature, anything the client wants to use that helps them feel that sense of regulation and calm and sturdiness. And it can also be used in between sessions. So sometimes I'll make a recording of my voice conjuring up this resource for them so that they can use it in between sessions. And again, it just is the fewer experiences that someone's had of positive connection, the more we need to resource. But I also want a word of caution that and we might talk about this later, but some clinicians stay here forever and they resource when, again, like I said, sometimes the best resource is getting into the work and realizing, wow, I can do this and I'm okay. So we want the client to feel sturdy enough to go forward, but we also want to be careful we don't send the message that we think they can't handle it or that we can't handle it. So we want to stay here long enough to feel that they're sturdy and safe enough. They have a wide window of tolerance. They can keep that dual attention, but we also want to keep moving forward into the next phases of treatment.
Yeah, and that's really important to think about. And I think as clinicians, we do protective of our clients and recognizing that making space for the discomfort that may be inherent in practice, even though it sounds like such an intentional modality that like where you're providing resource and strength, but being able to keep that forward momentum and communicate that you believe in the client's resilience. And as you're talking through that process, I do a lot of compassion focused therapy, and there's this idea of utilizing like either compassionate memory or compassionate imagination. So recognizing that some people don't have the memory well to pull from where they could recall strong role models for compassion or being treated with compassion. So then being able to generate new sort of anchors. And it sounds like the therapist joining the patient in a really creative process where they can start to develop that if it doesn't naturally come from their lived experience or memory bank that may be available to them.
Exactly. And sometimes it's the therapeutic relationship itself that's the resource for the client. Right here, right now with you, actually, is the first time I've talked about this and felt safe enough. Great. Notice that. What are you feeling? What are you thinking? You can seize that kind of a moment and develop a resource then and there.
Yeah, absolutely. That's really helpful to think about and just supports these other things that we know that the therapeutic relationship is so important in the healing process. So leveraging that in a very specific and explicit way in those moments. So I think you started to mention this in some of the challenges that might come up in implementation. But are there other common challenges that therapists may face when implementing EMDR? And what are your thoughts about how to address those challenges? Oh, absolutely.
Thank you. So, when I think about the challenges that I experience and that I hear about most in my consultation groups, the first one that comes to mind is not using it enough for the exact reasons we've been talking about, that people are afraid of seeing strong negative affect in their clients. They're afraid of that they're causing harm. And it's a catch 22 because I think it's by practicing and experiencing when you see, oh my gosh, once the person does this processing and come out the other side, they feel so much better. They feel this, if you really start to see and believe that by processing, you're helping someone release, you're helping someone drain a wound so that they can heal. So the more you practice, the more you're going to see that in your client and it'll give you more confidence. So I would say one thing we really have to help our consultees do after the training is to keep using it, keep practicing it. And I think one way to help our clinicians do that is we tell them to start with the clients with whom they feel the most comfortable, to close their eyes and picture those one or two or three people that when they walk to the door, they know that if they make a mistake, it's okay, right? They know that the relationship is really strong, that if there's a rupture, a mistake, that they feel really sturdy in that relationship. And that's a really nice place to start. I think a realistic problem that comes up a lot is with insurance or time constraints or the setting a person works in. And I think that's valid because I don't think you want to open some of this stuff up when you don't have time, when you don't have adequate time, or we've had people train with us in school-based systems. I wouldn't want to send someone to math class after opening them up for their trauma in a processing session. So sometimes they can only use elements of EMDR, the resourcing, some of the target assessment questions to look at things more deeply. But I think that is a realistic constraint that you do want to have enough time when you're doing EMDR processing. And then I would just say, again, not building a good enough relationship, processing too soon, staying in resourcing forever, like I mentioned, and not getting consultation. I think to gain that confidence, get consultation, get immediate practice with your consultant so you get immediate feedback on your work, bring tapes and recordings of you with clients, which is very scary and vulnerable, but really important to be able to look at your own work and share it with your consultant to get that feedback. And again, I think why I appreciated Dr. Zangwill's approach is this is not a panacea. It's not magic. I think if you have someone with a wonderful childhood and one car accident in adulthood, yes, this can be like a miracle. 1 or 2 sessions, PTSD gone.
Right.
But for most of us, that's not who we're working with. So I think knowing this is a process, not a magic fix, and just staying with it and trusting in the process.
Yeah. Do you have any recommendations about appropriate session lengths typically, or even like applications of whether this can be done effectively via telehealth, or if there's recommendations to do it primarily in person?
Yeah, we were very worried about doing virtual trainings and virtual EMDR, and we're actually quite pleasantly surprised by the results. Again, it comes down to a lot of choice. I have one client who was raped in college, and she says, I absolutely want to do my session virtually, please, because I don't want to walk home in the dark after crying. I don't want that sense of vulnerability walking in New York City alone. I want to be in my room where I can ugly cry. I can really feel safe and comfortable. And I have another rape victim who says, oh my God, Elizabeth, I don't want to process my rape in my bedroom. I'm going to come to your office and I'm going to leave it there. And then I'm going to be with you. And I know that then I can go home and that is not in my space at home. And I think both of those make sense.
Yeah.
So in terms of virtual in person, I leave it to the client's choice. And in terms of
Session length.
yes. So I would say if I'm going to do the processing, I really like to have at least 60 minutes. Some clinicians prefer 75 or even 80 if possible, even 90. And I know some people do intensives where they really do hours at a time and focus on something deep, but I would say at least 60 minutes. Now, there are clinicians who do it in a 45-minute, 50-minute session. I just think it's more challenging, again, because you're opening stuff up. And if you're pushing the gas, you want to make sure there's time to push the brakes and inhibit and make sure the person, again, feels shored up enough to go back into the world. So I think it depends on the client. Some people can really get in there and get out. But some people, I would really not want to do that with them.
Yeah, absolutely. That makes a lot of sense. We spoke before about how EMDR really can be adapted very effectively to work with folks from diverse cultural backgrounds. Any specific challenges that you think come up in terms of providing EMDR in a culturally responsive way or with specific marginalized communities that therapists should keep in mind?
Yes, I think cultural humility is just like with any psychotherapy, incredibly important with EMDR as well. So we always want to approach our clients with respect, with validation, and with curiosity. And I'm a white cisgender therapist, and I think we're beyond the time of being blank slates that comes into the room with me, and I own that and I name that. And in being the therapist, there's also a certain authority in that. So I think not being afraid to have those conversations with clients really openly, and that the labor is on me, not them, to bring it up, because it shows them we can talk. We don't have to talk about this, but I'm open to talk about this, right? And give them the choice. I think the other thing to really consider with processing with more marginalized communities, and like you mentioned, we use safe enough because just like our clients going out in the Bronx to say I'm safe just seems like a false promise. We know that being in certain gender identities, certain colors of skin in our country, in the world, are not safe. And we might process a painful traumatic memory or a memory of racial oppression or discrimination, but they're going right back into that world. So I think what we can do is really validate that, not pathologize it, really witness. And what I love about the processing aspect of EMDR is the imagination is the limit. So you can say to a client, if you could picture this scene moving towards justice, what would it look like? Not as a rehearsal, but in their imagination, they may be able to fight back, to flee, to have a voice in a way that is not safe for them to do in the outside world. And they may not be able to believe I'm safe or I matter in this world. They might not be able to, but can they believe I can find safe enough people? Can they believe my voice matters even if it's dismissed? I have the right to take up space. I deserve justice, right? So the more that we can allow for this type of empowerment and agency and hope, we can at least start to make dents in that internalized oppression and validate and witness.
I think that's really powerful, especially right now in this moment of history. I think a lot of clinicians are feeling really challenged and limited in how to support their clients, particularly those that may be gender expansive, as you mentioned, those that might have varying mm, citizenship statuses or in this country. or people of color. I think absolutely right now it's a time where if we are not acknowledging these structural oppressive factors that are going to impact and are impacting the daily lives of our clients, we're doing a disservice. So I think you talking about what finding those spaces for empowerment and the beliefs they'd like to hold, and while being with the realities of what they have to contend with when they sign off their session or walk out of your office, is incredibly powerful. And I think just the way that you walk through it feels like resonates with me with really helpful guidance for therapists, where I think a lot of us are seeking, like, what do we do now? Like, what are we supposed to do? So that was incredibly
Absolutely.
helpful.
I also think knowing we're going to make a mistake, that it's inevitable, that as a white person, I don't know someone's full lived experience, or even with another white person, I might project my experience and miss something. So I think with all of our clients, knowing we're going to make mistakes, there are going to be ruptures. But I think what's wonderful is that in those moments where we can say, I'm so sorry, that must have felt terrible when I XYZ, that we take accountability, that we meaningfully apologize, and that we have the capacity to repair without going away or without retaliating. That in and of itself can be incredibly healing. I think just don't be afraid to talk about these things and don't avoid things because you're scared and it feels delicate.
Yeah, no, absolutely. I think that's really important, and just how powerful it can be to take accountability. And accountability doesn't have to be like punitive or shameful, but it is incredibly important. So, how can therapists integrate EMDR into their practice if maybe they're using other modalities currently? And are there particular approaches that complement EMDR?
Yes, I would say not only can you integrate EMDR with other modalities, you should. And I will probably upset a few EMDR therapists in saying this, but I think it's better with other modalities integrated. For example, I use schema therapy to really help me with case conceptualization, for me to really understand the way my clients think and feel and move throughout the world. Schema therapy really helps guide my conceptual framework. I think IFS works beautifully with EMDR because in that processing, you're inevitably going to come across a protector part that says, I'm not going there. So if you have a way to work with parts work in a non-shaming, non-stigmatizing way, I think IFS can be incredibly helpful. And I think even CBT, psychodynamic work, somatic work, what gets the client in their body, mindfulness, where you're already doing that dual attention, DBT, where you're helping them to tolerate distress, for example, if someone might need more distress tolerance work before doing the processing. So I always tell clinicians and trainees, don't throw out your current modality at all. This works beautifully with whatever you're already doing.
Yeah, I love that. And that speaks to my heart as an integrative therapist. But it is really interesting to look at the potential synergies. Like you said, something like internal family systems, like how that could potentially just map so beautifully onto a treatment approach like this. And I think part of it is different things that resonate with different people, and finding the way to approach it that really clicks for them, that is deeply meaningful for them. This idea that, particularly when we're working with diverse patient populations, the idea that everything is going to land the same for every person, when there is just such complexity to the human experience and spirit, I think it can be limiting. So I love that you're inviting folks to actually explore integration. And I think that's some of that's also developing our personal identity as therapists and how we are most effectively of service. Yeah, I really appreciate that. So, for clinicians interested in learning EMDR, what advice do you have for getting started? And maybe what should they be looking for in a training program or know about the process to become competent and be able to deliver this treatment?
Yes. So I would say there's so many trainings that have popped up since COVID. So it's really hard to navigate. So that's a great question. I would say look for an EMDRIA approved training. That's EMDRIA.org. And if you want something in person, you can see a list of trainings in your area. There are also virtual options if that's more convenient for you. But I really recommend going through EMDRIA. Of course, I recommend the training where I work here in New York, which is EMDRandtraining.com. But what I love about our training, and you should look for in yours, is that there's a good trainer to trainee ratio because you want to get a lot of practice as the clinician. You want to get practice as the client and an observer. And we know the least effective way to learn is sitting there passively listening. The next best way is through demonstration. But the best way is practice with immediate feedback. So you want a facilitator, or sometimes they're called a guide, in the room with you, giving you immediate feedback on what you're doing so that you can feel confident. Because again, we know one of the main problems is people don't use this. Knowing that the basic training is several days long, and then there's 10 more hours of group consultation that follow the basic training. So it is a lengthy process. But Francine began expanding it because they found when they had it on just a weekend, Dr. Zangwill said people would leave and then either not use it or come back 5 minutes later, and that the group consultation really helps people get to practice and ask their questions. And I would say, as I continued to become certified, then a consultant and a trainer myself, it does take time like any modality, right? I think it just takes time to have that reflex for it to really be in your bones. So just keep practicing. And again, look for a training that's EMDRIA approved where you get a lot of opportunity to practice.
Absolutely. That is very helpful. Before we wrap up, is there a key takeaway or insight you like to share with therapists exploring EMDR?
First, I would say if you work with trauma, I really recommend you get trained in EMDR. And I like to say if you work with human beings, you are working with trauma. So I think EMDR is just probably the best investment I've made in my career in terms of time and energy and impact. So I really recommend getting trained. I also really recommend trying EMDR as a client. If you listen to this and are cynical, you move your eyes back and forth, you tap yourself and you're better. If you have it available to you and you have access, I really recommend trying it as a client and feeling how powerful it is for your own work. Because I think as therapists too, it's really important we continue to do our ongoing work. So those are the two things that I would highlight in terms of takeaways.
Amazing. Part of the reason I was passionate about getting an EMDR expert on was because my experience in the last year with an EMDR therapist and doing this work, and it being so impactful, being on the other end of it, and it being having overlap with some of the treatment approaches I've utilized, but also being so unique and incredibly helpful has been a wonderful experience for me. And I think you have really, in terms of having me get interested as a clinician, really sold me today. Just your passion is so clear, and how much this has been an incredible approach for you personally and professionally. So I really do appreciate your time and insights on this so much. And I would love for you to just maybe share where listeners can learn more about your work or connect with you or access maybe any helpful EMDR related resources.
Absolutely. So as I mentioned, EMDRIA.org is a great general resource. If you have questions for me or are interested in our basic training, you can find me at www.armstrongpsychotherapy.com or email me at earmstrongpsychotherapy@gmail.com. And the training that I work at, again, is www.emdrandtraining.com with Dr. William Zangwill, my mentor. And I think we have a wonderful training with amazing facilitators and a lot of opportunity to practice.
Yeah, thank you.
Thank you so much, Shaina, for having me. It was great to be here.
Absolutely.
Thank you for joining our community on the Affirming Minds podcast. If you loved this episode as much as we did, please follow us wherever you listen to your podcasts and share it on your socials. If you want more information about how this podcast can add to your continuing education credits, visit affirmmentalhealth.com. And remember, let's affirm, heal, and grow together.